Good morning or good afternoon, depending on where you are. I'm Bianca Frogner. I'm a professor at University of Washington and director of the Center for Health Workforce Studies at UW. I'm also part of the leadership committee for the award network, or the Advancing Workforce Analysis and Research for Dementia network, that's housed at UCSF, and the PI is Joanne Spetz, who we are happy to have here today with us. I'm really excited to have you all join us today for our monthly webinar series here in October, where we will be hearing from two excellent speakers about a new study that just came out on post-acute care service use and outcomes among traditional Medicare and Medicare Advantage beneficiaries. This is, again, part of our monthly webinar series. The session will be recorded today, so you can always go back to our website to hear it again or to share it with others, which we certainly encourage you to do. And all of our prior webinars have been recorded with a couple exceptions. So you can also find those on the Award Network website, which I certainly encourage you all to go back and listen to them, because there have been some excellent speakers to date. And we have a wonderful lineup coming up, which we're trying to get onto our website so that you know ahead of time what additional speakers we're going to have. Next month, we have a couple of speakers from the VA services around the country who will be speaking a little bit more to how the VA system has been caring for patients with Alzheimer's. And so that should also be up on our website soon. On the lower right hand side of your screen, you can use a QR code to go to our website to see future webinars, past webinars, and also to provide any thoughts that you might have on other webinar topics that we should pursue in the future. So I certainly encourage you all to check that out and contribute. So I do want to just also share that this work is done with a wonderful committee. And so the folks here on the slide here are our other webinar committee members. Hui-Wen Xu will be the one hosting today's presentation. He's an assistant professor at University of Texas, the medical branch. And just a couple other heads up, we have a pilot award program that has been released, and the due date is October 30th. So there's still time here to apply for this up to $20,000 pilot award program. There is a recording available on the website if you want to know a little bit more about the program, as well as the full RFA that's available online. And also, there is keep an eye out on our website, because next July, we're planning to do a summer institute. So while the dates have not been set specifically yet, we do hope to host a summer institute where folks can learn more about how to care for patients with dementia and the workforce needed to do so. It will be in San Francisco, so mark your calendars and prepare for that. And with that, I'm going to go ahead and stop sharing and ask Hui-Wen, our webinar host for today, to join us. So please take it away.
Thank you, Bianca. Hi, I'm Hui-Wen. Welcome to today's webinar. I'm honored to introduce our two distinguished speakers today from Vanderbilt University. First of all, we have Emma Acola. Emma is a doctoral student in the Department of Health Policy at Vanderbilt. Prior to attending Vanderbilt, she spent 4 years working in federal health policy in Washington, D.C. She worked as a research assistant at the Medicare Payment and Advisory Commission, where she focused on various issues related to Medicaid payment policy. She then joined the American Medical Group Association, where she focused on regulatory issues surrounding physician payment policy. Her current work focused on how Medicare payment policies can be leveraged to align incentives for providers to deliver higher quality and more efficient healthcare for older adults. Emma received her Bachelor of Arts in Public Policy Studies from Duke. Second, I think Laura is Emma's advisor, which is cool. We have Dr. Laura Koyihan, who is an associate professor in the Department of Health Policy at Vanderbilt School of Medicine. Her research focuses on policies that promote better health outcomes and provide affordable service for beneficiaries with Medicare and Medicaid, especially those who faces healthcare barriers due to frailty, disability, or limited socioeconomic resources. Dr. Koyihan's research has examined management care alignment incentives for dual eligible beneficiaries post-acute care benefits in Medicare Advantage plans, Medicare spendings for dual eligible beneficiaries, and factors affecting Medicaid participation among Medicare beneficiaries, so a lot of Medicare and Medicaid. She currently leads a larger federally funded research grant on Medicaid and Medicare policies that can support aging in place for older low-income adults with diabetes and dementia. Dr. Ko Yihan holds a PhD in health service research program, health service research from Brown University, and a master in health policy management from Harvard School of Public Policy. So just a little logistics. We will have Emma to present for like 20 to 25 minutes. Then maybe we can have a few clarification questions. And after that, Lauren will present another 20 minutes or so. And we will leave 10 minutes or, at the end for more in-depth discussions. So Emma, floor is yours. Thank you.
Thank you for that introduction, Dr. Zhu. I will share my slides. Thank you. Hello, everyone. So today I'm going to present work that just came out a couple of months ago in JAMA Health Forum, where we look at post-acute care use and outcomes among Medicare Advantage and traditional Medicare beneficiaries. And I'd like to take a second to thank my co-authors, Dr. David Stevenson and Dr. Laura Keohane, for their mentorship and their contributions to this work. So to quickly begin, I have no conflicts of interest that I need to disclose, and this work was also funded through a grant from the National Institute on Aging. So some background information: Medicare beneficiaries who are discharged after an acute care hospital stay oftentimes receive post-acute care services, and in some cases, these services can be delivered to patients without a prior hospital stay. Medicare spending in 2020 for these services totaled $57.9 billion, prompting policymakers to focus on ways that the Medicare program can efficiently deliver these high-quality post-acute care services to beneficiaries. And so in addition to this high spending on this sort of care, there's also been found to be geographic variation in Medicare spending that's been mostly driven by post-acute care services. And so traditional Medicare and Medicare Advantage, they have differing incentives that may reduce the use of post-acute care or maybe encourage the overuse of these services. So traditional Medicare is largely fee-for-service reimbursement system, may encourage overuse of unnecessary post-acute care, while capitated risk-adjusted payments in the Medicare Advantage program may incentivize plans to curb the use of unnecessary services. Plans have several levers that they may use in order to ensure efficient use of services. So they can use things like utilization management, prior authorization, provider networks. They may also steer patients towards lower cost settings, or they may discharge patients home with no post-acute care. And so the literature finds that these tools are quite effective at limiting the use of post-acute care. Studies find that MA enrollees use less post-acute care services relative to those in traditional Medicare, and they're more likely to be discharged home with no post-acute care or to lower cost settings. This differential use does not translate to negative outcomes in administrative data. Medicare Advantage patients were found to be less likely to be, or were found to be discharged home, more likely to be discharged home successfully, less likely to be readmitted post-discharge, and they experienced no increased risk of mortality relative to those in traditional Medicare. However, these studies exclusively relied on the use of administrative data, and they didn't assess post-acute care use or they didn't assess patient experience of care within these settings. And so while plans may be better aligned to deliver this care and do so more efficiently, there's also been some evidence that suggests that MA enrollees are more likely to use lower quality skilled nursing facilities and home health agencies relative to traditional Medicare beneficiaries. And so these findings may have implications for the way that patients perceive the care that they're receiving. And so given this work, our studies sought to use survey data to assess patient-reported use of post-acute care and outcomes among community-dwelling Medicare beneficiaries by enrollment type. We also performed analyses among the dually eligible population, a group of beneficiaries that have high participation in managed care and high use of post-acute care services. We also performed analyses on certain subgroups of patients who may be more likely to need post-acute care. And so by focusing on those populations of patients who experienced similar health events or had similar conditions in the past year, we aim to minimize any unobserved differences in health or functioning between MA and traditional Medicare beneficiaries. So we used rounds 5 through 7 of the National Health and Aging Trends Study and linked enrollment data in our study. The NHATS is a survey that's nationally representative of a cohort of Medicare beneficiaries that are age 75 and older. Our analysis included beneficiaries 70 years and older who are community dwelling and had linked enrollment data, and also complete and valid responses to all survey questions. So our statistical analysis followed the following process. We used Pearson's chi-square tests to make our comparisons between the two groups of beneficiaries. Our analysis first began by comparing patient-level characteristics of study participants by their enrollment type. Participants who had at least 1 month of MA participation during the year the survey was fielded were considered to be MA enrollees, and those who had 1 month of partial or full dual eligibility during the year the survey was fielded were considered to be dually eligible beneficiaries. We then report comparisons of post-acute care use by each round by enrollment type. And then lastly, for those who did report using post-acute care, we pull the analysis by using the participants' first reported instance of post-acute care, and then we examine differences in outcome measures. And we weighted our results by survey weights in order to account for complex survey design. We examined the following use measures in our study. We looked at self-reported post-acute care in the last year, the site of service where the beneficiary received their services, the duration of time they received services, as well as the reason for needing post-acute care. Our main study measures related to self-reported outcomes were things like functional improvement, both during and after services ended, as well as whether the participant felt like they met their goals when post-acute care ended. We also assessed a number of patient-level out characteristics in order to determine the comparability of these two groups based on observable characteristics. And so that left us with an unweighted study population of 16,946 community dwelling older adults. 2,357 of those were post-acute care users. And so when we compare characteristics of the post-acute care users by enrollment type, we do find few statistically significant differences. MA participants were more likely to be dual, non-white, and they reported they were slightly more likely to report being in fair or poor health relative to traditional Medicare beneficiaries. And in both groups, they reported similar rates of hospital use in the past year. Among duals, you can see that we observe almost no statistically significant differences between Medicare Advantage and traditional Medicare duals. In addition to those few differences on observable patient characteristics, we also notably found that the reason for needing post-acute care did not differ between these two groups either. And so I'll first show you results for our overall study population, and then for participants who had reported a hospital stay in the last year, since there are likely unobservable differences in health status that we're not able to account for that could be confounding our results. So we find in the overall study population that in each round, MA participants do report less use of post-acute care. So between 16.2% and 17.1% of MA participants reported using post-acute care compared to 22.4 to 24.1% of those in traditional Medicare. Among hospital users, these findings are also fairly consistent, where we find that hospital users report using less post-acute care, although in round 6, that finding does lose statistical significance. Our results also show in the overall study population that MA participants do report shorter durations of post-acute care use. And so roughly 30% of MA participants report using post-acute care for 4 weeks or less, compared to 24.3% of traditional Medicare participants. Among those who did report using post-acute care services, we then look at our functional improvement outcomes. So we find that MA enrollees in both the overall population and amongst those who reported a hospital stay in the last year, that they were less likely to report functional improvement while receiving post-acute care. So 63.1% of MA enrollees in our overall population reported functional improvement while receiving post-acute care, compared to 71.7% of traditional Medicare participants. And among those with a hospital stay, we see that 64.9% of MA enrollees reported improved functioning, compared to 73.9% of those in traditional Medicare. And in both populations, we see that MA enrollees are less likely to report that they've met their goals when services ended, or we find in the overall population, or we find that both groups are less likely to report that they met their goals in the at the end of services. However, that result was not statistically significant. So among our analysis for the dually eligible population, we see similar patterns as to the overall and the hospital users in our study. We see that MA duals report less use of post-acute care. However, these results were not statistically significant, although we may have been underpowered in our study to detect those differences. And so looking at some of the subgroups of patients, those who experienced a fall in the last year, had hip or knee surgery, or who had a history of osteoporosis or arthritis, we also see those trends in use of post-acute care hold. And while I don't have that data on this slide, for example, we see that patients who experienced a fall in the last year, 25.6 to 26.9% of MA patients reported using post-acute care, compared to 30.7 to 33.1% of those in traditional Medicare who reported experiencing a fall in the last year. Our findings of less functional improvement while using services also held in these populations, where you can see that 60.1% of MA enrollees who experienced a fall reported functional improvement while using post-acute care, compared to 70.7% of traditional Medicare beneficiaries. Our findings were consistent with respect to whether beneficiaries felt like they met their goals, although those results were not statistically significant. And so, of course, there are limitations to our analysis. First of all, differences in the outcomes that we analyzed may reflect unobservable differences in health between these two populations, particularly because historically favorable selection within the Medicare Advantage program has meant that healthier beneficiaries do opt to enroll in the MA program. So these beneficiaries may be folks who are less likely to need or use post-acute care compared to traditional Medicare beneficiaries, and that could partially explain some of our findings. However, when we look at outcomes, this bias may be flipped, because plans can do things like limit access to post-acute care through utilization management practices like prior authorization. MA post-acute care users may be potentially in worse health relative to traditional Medicare post-acute care users. Also, we found few significant differences by managed care enrollment across multiple characteristics of post-acute care users. We also performed a number of subgroup analyses for beneficiaries who experienced similar health events. or had similar conditions, and we find comparable results in terms of service use and functional improvement. However, our study is one of the first to use self-reported data to capture self-perceived functional improvement among post-acute care users, and we also examine a broader range of rehabilitative services, such as outpatient clinics. And so we find that MA enrollment is associated with less improvement on some patient-reported measures. And this highlights the importance of using self-reported outcomes in improving care delivery processes. Differences in perception of improvement may also be related to utilization management practices. MA enrollees there's evidence suggesting that MA enrollees use lower quality skilled nursing facilities compared to those in traditional Medicare. And that's perhaps due to the availability of provider networks within MA plans. Also, by requiring prior authorization for post-acute care services, plans may require patients to end their use of these services before the beneficiary is ready, and that could also lead to higher levels of dissatisfaction with care. So as enrollment in the Medicare Advantage program continues to grow, it will be necessary to also understand the differences in the use of these services and outcomes by enrollment type, particularly if this differential use is associated with the different perceptions of care for those in Medicare Advantage. Our findings also have implications for Medicare's move to value-based care. Based on prior evidence that suggested that geographic variation in Medicare spending is largely driven by post-acute care, several Medicare value-based models, alternative payment models, have targeted reducing unnecessary use of post-acute care. And evaluations of these models and administrative data, the Medicare Shared Savings Program, as well as mandatory bundle payments, have found that these models achieved savings by decreasing post-acute care use without adverse outcomes in administrative data. However, our findings suggest that that self-reported measures may introduce evidence of potential declines in patient satisfaction that Medicare should investigate as it seeks to expand the use of alternative payment models. Thank you all for attending and listening, and my contact information is included on the slide, and I'll be happy to answer any clarifying questions before handing it off to Laura.
Thank you, Emma. It seems we don't have questions from the audience, but I do have one clarification question. So when you define post-acute care, what kind of service do you include? You mentioned briefly. Can you expand a little bit?
Yes, so the survey asks about any rehabilitative care that the beneficiary received. So those within a nursing facility, in an outpatient setting, any physical therapy, occupational therapy that a patient receives either inpatient or outpatient in like a OT's office or a PT's office.
So it's a broad definition, almost like any kind of post-acute care rehab.
Yeah.
Okay. Okay, cool. I think then if you have any other questions, please don't forget to type in the Q&A function, and we will address them at the end. Thank you, Emma. And Laura, it's your turn. Thank you.
Great. Let's see if I can get through the biggest hurdle, sharing my PowerPoint slides successfully. All right. So I think you all should be seeing the title slide. Thank you so much for having me and Emma today. I'm here to give a kind of big picture overview of Medicare Advantage and post-acute care, and give you an overview of some of the things that I think are important to watch in this space as Medicare Advantage continues to become more popular. So I'm going to just acknowledge that I have no conflicts of interest for this work and disclose funding from these various sources. And I'm going to pick up where Emma left off. And she raised the implications that these have for broader value-based care and alternative payment models in Medicare. And I wanted to loop back to that point. So in 2013, the Institute of Medicine published this large report that identified post-acute care as the largest source of unexplained variation in traditional Medicare spending, with the upshot being, why is Medicare paying more for post-acute care in some parts of the country without evidence that it improves outcomes? And this report came out, at a pretty key point in Medicare history. It was published just as Affordable Care Act value-based models like bundled payments and accountable care organizations were launching. And it also was published as Medicare Advantage enrollment was set to double over the next 10 years. So as these alternative payment models and value-based approaches were launching, it was very loudly broadcast that post-acute care might be a particular area to focus on for reducing spending. And there are several characteristics about post-acute care that lend it to, perhaps being a target for these value-based models. There's little evidence available about the best dose of post-acute care. Is it feasible for people to be treated in lower intensity settings just as well as they would be treated in higher intensity settings? So, for example, could a home health agency provide post-hospitalization services just as well as a bed in a skilled nursing facility? There's also very little evidence about the appropriate duration of services. Does 2 weeks in a skilled nursing facility make a big difference relative to 3 weeks or 4 weeks? And part of this speaks to just the nature of post-acute care and the population that uses post-acute care. They're often people with multiple chronic conditions and underlying frailty, so it's hard to identify if there is a specific protocol for condition X, Y, and Z when a person might be dealing with multiple different conditions. And so I wanted, since we're in a workforce seminar, to talk about, some of the implications of this value-based approach to post-acute care for the workforce. So one of the biggest issues is that the shift to value-based care could put a potential financial strain on post-acute providers, especially those who have poor quality performance or who have limited negotiating power, either negotiating power with Medicare Advantage contracts to negotiate favorable contracts, or limited negotiating power with organizations like ACOs that are trying to streamline and optimize services for their beneficiaries. This financial strain could restrict post-acute providers' ability to hire and retain staff, which is really one of the keys to having high quality care in this sector. I also want to acknowledge that, for post-acute care providers, they might be seeing shifts towards more clinically complex patient populations. For example, if a managed care plan decides that a patient could be treated in a skilled nursing facility instead of an inpatient rehabilitation hospital, then the skilled nursing facility is probably seeing patients on average that are slightly sicker and have more needs than the average previous nursing home patient. These types of pressures create increased need for adequate staffing levels and for advanced training among the workforce in each post-acute care setting. Also, with value-based post-acute care, there's a greater emphasis on patient outcomes and measuring patient outcomes, which begs the question of what factors are within the provider's control. So, for example, the study that Emma just presented found decreased satisfaction with functional improvement. Is that because of the providers that Medicare Advantage beneficiaries were seeing, or was it because Medicare Advantage plans might have been putting restrictions on how much post-acute care they could receive? It's hard to tease apart those type of issues in ways that might be frustrating for providers who are being paid under these schemes. So half of the Medicare population is now in a Medicare Advantage plan with incentives to curb post-acute spending. We crossed the 50% threshold recently, and the Congressional Budget Office is estimating that in 10 years, over 60% of the Medicare population will be in a Medicare Advantage plan. As Emma explained very clearly, Medicare Advantage plans are known to have lower post-acute care use than traditional Medicare, which begs the question of, what factors might be influencing that lower post-acute care use. And for some reason, let me see if I can advance a slide. There's an excellent study by Emily Gadwa and team that came out in 2019, where they interviewed stakeholders across multiple parts of this equation, discharge planners at hospitals, planners at skilled nursing facilities, directors of nursing at skilled nursing facilities, case managers at managed care plans, directors of managed care plans, to get their perspective on how the transition to SNFs went from a managed care perspective. And I think this quote from a director of nursing at a SNF is particularly telling. He or she says, "My difficulties with managed care is that they want the person out and they don't want them better." So even if we say, like, we need more time, we need another 5 days, they're pushing to get them out because they're getting reimbursed from Medicare, so they want them out as fast as possible. I kind of feel like I'm working against managed care, where with people that just have Medicare, basic Medicare, we don't have that issue. So there's this tension between Medicare Advantage plans with this incentive to save money on post-acute care, whereas skilled nursing facilities in the traditional Medicare system, since they're paid on a per daily basis, they don't usually have a lot of pressure to get patients out the door as fast as possible. And SNFs might end up losing money if they're getting patients out faster rather than later. So there is also some evidence that Medicare Advantage plans pay less for SNF. It's difficult to study because there are limited national data sources. And I have to say, this is the only evidence that I could find in the SNF sector. There's probably even less in the home health sector. MedPAC issued a report earlier this year. And as part of that report, they suggested that SNFs might be accepting lower payment rates for Medicare Advantage plans for the same services that are provided under traditional Medicare, based on publicly filed reports from for-profit chains, and also based on surveys of SNFs. There's estimates that payment rates from Medicare Advantage for SNF daily services are about 20% to 40% lower than what traditional Medicare would pay. It could be that SNFs are providing less intense services to Medicare Advantage enrollees, but it's unlikely because MedPAC also found that Medicare Advantage and traditional Medicare SNF users have similar SNF users. Since we're talking about a managed care plan, you might be concerned that Medicare Advantage users of post-acute care might be expected to pay more for post-acute care in Medicare Advantage, but there are actually numerous cost-sharing protections for Medicare Advantage post-acute users that came into effect with the Affordable Care Act and also after that. Plans actually cannot charge more cost-sharing than traditional Medicare for skilled nursing facilities and home health services. The only exceptions are when a Medicare Advantage plan offers a lower out-of-pocket limit across all medical services, with the idea that that out-of-pocket limit would provide adequate protection. This measure was put in place to prevent plans from using cost sharing for post-acute care services as a way of signaling to beneficiaries that they shouldn't enroll in plans. And so the idea is that we're preventing Medicare Advantage plans from discriminating against beneficiaries who need expensive services. We found in some work that cost sharing reductions under CMS mandates are not associated with increases in SNF use, as you might expect when you lower the cost of services. But we can examine whether Medicare Advantage plans were able to use some of the other methods that Emma mentioned in her talk, things like prior authorization, limiting plan networks, other strategies to try and lower the use of post-acute care services. So I wanted to highlight a few policies to watch in terms of thinking about the future of post-acute care in Medicare Advantage. Three come to mind. There's new regulations out this year on prior authorization and coverage criteria that could have quite an impact on how post-acute care is provided in Medicare Advantage. There's growing use of Medicare Advantage supplemental benefits, which exist in this weird space, partly between post-acute care and partly between long-term care. And then finally, I'll highlight the growth of special needs plans, which will be, I think, particularly relevant to beneficiaries who use post-acute care because they highlight some of the higher need populations in the Medicare program. So I'll start with new regulations on prior authorization and how Medicare Advantage plans can determine what should be covered. These regulations are based on concerns that Medicare Advantage plans might be inappropriately denying services across multiple sectors. There's a report that came out last year from the Office of Inspector General in the Department of Health and Human Services. They sampled denied prior authorization requests and denied claims from the 15 largest Medicare Advantage insurers. And the Office of the Inspector General highlighted that skilled nursing facilities and inpatient rehabilitation facilities had a higher number of denials relative to other sectors. And the rationale for these denials was that Medicare Advantage plans claimed patients could be treated in less intensive, less expensive settings. So, for example, suggesting that someone didn't necessarily need a skilled nursing facility stay, they could be treated at home with a home health agency instead. The analysis by the OIG office determined that many of these services would have actually been covered if the beneficiary was in traditional Medicare and not in a Medicare Advantage plan, which is contrary to how Medicare Advantage coverage should work. Medicare Advantage plans can restrict their benefits in some ways, but in general, they do have to cover services that would be covered in traditional Medicare. So this April, CMS issued new Medicare Advantage regulations clarifying a lot of these points and clarifying that plans do have to comply with existing traditional Medicare coverage determinations, and the regulations make it much more explicit about what sources of information plans should rely on to see if traditional Medicare has already spelled out explicitly what services are covered. There are a lot of services where Medicare does not actually explicitly spell out what services are covered. And so when there's not clear traditional Medicare criteria, plans can create evidence-based criteria as long as it's based on sound evidence like national treatment guidelines, and as long as the plans make it publicly available so that providers and members can see how their care is being evaluated. One of the most important parts of the new regulations in terms of post-acute care is that plans can only deny post-acute care setting in a specific setting if the care does not meet traditional Medicare criteria for that setting. So for example, it's not enough for the plan to say, well, yes, this person is could be treated in a SNF or could be treated in home health, and say, instead, because they could be treated in both settings, it's more appropriate to treat them in the home health setting. The regulations made it very clear that Medicare Advantage plans just have to meet whether the beneficiary could be treated in a SNF, for example, and don't have additional authority to say whether it be more cost effective or appropriate to treat them in another setting. So this has the potential to really dramatically affect how Medicare Advantage plans can issue things like prior authorizations or not for specific settings. There are also some broader national proposed prior regulations that are still on the table that would affect both Medicare Advantage plans and other insurers, like insurers on the ACA marketplaces. On the table is requiring that insurers provide a response to prior authorization requests within 7 days, or for urgent requests within 72 hours. That all insurers would have to provide a specific reason for why a prior authorization request is denied. And I have to admit, I don't understand all the technical details, but it seems like it would improve how data is exchanged for prior authorization requests and prior approval requests, and potentially cut back on the number of faxes that are flying back and forth between providers and insurance companies. So some insurers have already responded by starting with this renewed scrutiny on prior authorization, have started rethinking how they're doing prior authorization. So for example, United Health released a list of services that are no longer going to be subject to prior authorization. And I do want to give one caveat where, there are some advantages to prior authorization in that a provider can, be guaranteed in advance of providing a service that they will be paid for that service, versus denying a payment after a service has already been provided. So for example, one of the services that United Health has announced will no longer be subject to prior authorization in Medicare Advantage is the provision of wheelchairs. And while that sounds like it should streamline access to wheelchairs, there is the potential that some vendors might be concerned about providing a wheelchair to a beneficiary if it's less certain that they will be paid for actually providing that wheelchair. In this case, there might be advantages to being able to file a prior authorization request, get confirmation that a wheelchair would be paid for, versus delivering a wheelchair and finding out after the fact that the wheelchair is not paid for. So something to keep in mind in the back of your head when we're thinking about how we appropriately recognize prior authorization and when it might actually have some advantages for beneficiaries and providers. I also want to talk about Medicare Advantage supplemental benefits. So Medicare Advantage plans have always been able to offer services that are not covered in traditional Medicare. And the most, common of these supplemental benefits are things like vision coverage, dental coverage, hearing aid coverage. But starting in 2019, CMS issued regulations that allowed Medicare Advantage plans to offer a wider scope of supplemental benefits. And this new set of supplemental benefits is really increasingly overlapping between what we think of as classic post-acute benefits like home health care, what might be covered under a Medicaid benefit if someone is dual eligible, and this new category of supplemental benefits. So for example, starting in 2019, Medicare Advantage plans can offer benefits like in-home support services, adult daycare services, and caregiver services. Now you hear the phrase in-home support services and it might sound like comprehensive services, but it usually has significant limits on it. For example, they might only be available to members with specific conditions like diabetes or dementia. They might only be available to members who meet very specific criteria, like having had a recent hospitalization. They could get in-home support services for some time after the hospitalization. And there's usually measures taken like capping the number of hours that are provided to adults. So it would not be appropriate to classify these in-home support services as replacing kind of full-time provision of long-term services and supports. It does suggest that Medicare Advantage is kind of taking the slightly larger step into issues that affect the long-term care workforce as they're thinking about things like caregiver support and having more personal aid services, even just on a short-time basis for their members. The third and final thing I want to talk about in the Medicare Advantage space is the growth of special needs plans. In general, Medicare Advantage plans are open to all Medicare Advantage beneficiaries with a few very specific exceptions. Special needs plans are allowed to limit their membership to Medicare Advantage to Medicare beneficiaries who meet specific criteria. The most common of these plans are dual eligible special needs plans that are only available to beneficiaries who have both Medicare and Medicaid. The number of plans for dual eligible beneficiaries has increased a lot since 2010. And the other type of plan I want to highlight are institutional special needs plans. The number of institutional special needs plans has more than doubled since 2010. It's a small but important niche of the market, especially among nursing home residents. I'll start with talking about the dual eligible special needs plans. These plans can vary significantly in their degree of integration with state Medicaid programs. So we have, some of the most highly integrated dual eligible special needs plans might be a situation where the insurer has worked out a contract with the Medicaid state program. The dual eligible special needs plan that is provided by the insurer might complement a Medicaid managed care plan that is offered by the same employer. And there might be a fair amount of integration between, whether those two sides of the insurance, Medicare and Medicaid, are talking to each other and trying to coordinate benefits across the Medicare and Medicaid programs. Well, we can also have fairly loosely integrated Medicaid plans where the dual eligible special needs plan does have to have a contract with the state Medicaid program, but the contract might outline like pretty basic requirements about how the dual eligible special needs plan is communicating with the Medicaid plan about the beneficiaries' needs. There is very little evidence to date, and a lot of actually very recent evidence that outcomes are meaningfully different for beneficiaries in dual eligible plans than those observed in ordinary Medicare Advantage plans. And while we're talking about patient-reported outcomes, I think it's important to think about what matters more to beneficiaries. Whether or not your dual eligible special needs plans is integrated with your Medicaid benefits, or whether your Medicare Advantage plan includes your doctor and your hospital of choice in their network. And we haven't, had a lot of data on those type of questions, partly because it's also difficult to get data on Medicare Advantage networks, although that is improving in more recent years. The other type of special needs plan that's important to think about in the post-acute care space is institutional special needs plans. These can enroll beneficiaries who need an institutional long-term level of long-term care, mostly in nursing home settings, but this can also be people residing in the community who have supports that allow them to get an institutional level of long-term care. Many of these plans are provided directly by Medicare Advantage insurers, but there are also arrangements where nursing homes can partner with a Medicare Advantage insurer. And because the nursing home and its insurance partner is on the hook for all Medicare spending, there's a direct financial incentive to avoid expensive hospitalizations and, in an odd way, even an incentive to avoid SNF care, even though the nursing home is being paid for that SNF care. The advantages of this approach is that, we could be improving the provision of long-term care to avoid complications and avoid situations where someone could be, treated just as well in a nursing home as in a hospital, and providing financial incentives for skilled nursing facilities and nursing homes to hang on to that patient in the nursing home. The cons is that we also could be creating conflicts of interest for whether the nursing home has to decide whether to bill a patient as a private pay patient versus a Medicare SNF payment, because the Medicare SNF payment will kind of count across against their potential profitability as a Medicare Advantage institutional special needs plan. So there's a great article by Kaiser Health News that talks about some of these dynamics and how they play out for patients in some situations. So I'll close by talking about the implications of these policies for adults living with dementia. The new prior authorization regulations, in addition to potentially making it easier to access post-acute care, I think one of the big considerations for people with dementia is that hopefully it also makes it easier to navigate access. In many situations, we might be expecting patients to file appeals and be able to navigate an exceptionally complex system. By having, more clear guidance on when Medicare Advantage plans can or cannot deny post-acute care, hopefully that makes it an easier situation for adults living with dementia and their caregivers to navigate. For Medicare Advantage supplemental benefits, I think it's important in the space of dementia to recognize that these benefits might complement, but definitely not replace the provision of adequate long-term care for adults living with dementia. One of my concerns is that, there's already a fair amount of confusion about whether the Medicare program in general covers long-term care. I think, one of the potential drawbacks of these supplemental benefits is it might not be clear how limited the scope of these supplemental benefits are until you're in a position to need in-home support services on a more long-term basis. And then finally, with the growth of special needs plans, it's incredibly complicated to navigate the Medicare Advantage plan enrollment process and deciding whether to join Medicare Advantage versus joining traditional Medicare with Medigap. Or, when we have dozens of plans that beneficiaries can choose from, it can be difficult to decide which Medicare Advantage plan is best for you and what the real differences are between, for example, a dual eligible special needs plan versus an institutional special needs plan versus a regular Medicare Advantage plan. I think we need some unbiased resources to help beneficiaries, especially adults living with dementia, make those type of informed enrollment choices. So I thank you for your time and look forward to your questions.
Thank you, Laura, for this excellent introduction. It's quite comprehensive. So I don't know whether our committee member has any question. Yeah, okay, Bianca, go ahead.
Hi, thank you so much for this excellent presentation, both Laura and Emma. There's so much to try to digest here. And so I imagine others in the audience too are trying to piece it together. And even though I've spent some time in this area, it certainly has moved ahead faster than I can keep up. So I'm curious about what we know about maybe what the baseline expectations might have been for some of the patients prior, so and I might have missed that too in the presentations, because I'm just wondering, is it possible that people in MA plans may also expect something different about their care and outcomes? What do we know about the baseline expectations? Do we know anything? Do we have any data?
Yeah, no, that's a great question. Unfortunately, that's kind of one of the limitations that we can't really take into account, that like baseline functioning, or like you said, those expectations that might be differential between the two groups. So yeah, that's just something we can't account for in the study.
And maybe if I can just ask one other thing. So I think you try to keep track of people who kind of maintain some enrollment in here. I know there are switchers, especially from MA to traditional, and also obviously people leaving traditional to get to MA. But I'm curious, do we know, or have you seen or know anything about the switchers? And to what extent, maybe if people are not happy with their experiences with MA, if that might, some of what you're finding here may lead to switching. Is that something that anyone's going to be looking at in the future? Or maybe if you could just talk a little bit about switchers in general, what we do know about them.
Yeah, I guess our study didn't take into account those who like disenroll and move from MA and traditional Medicare or vice versa. But I think that there's been a lot of work that has examined switching, especially in the context of beneficiaries who have high complex needs or who experience some sort of health event or who even have ADRD or dementia. And they have found that those beneficiaries, I think, are more likely to disenroll and move into traditional Medicare from Medicare Advantage. In our work, yeah, I don't think there's any in this population, I guess, work to look at that in this context. But I think that other papers have found that it seems like there may be those dissatisfactions with maybe networks or even having care cut off or having to jump through hurdles like prior auth that may be contributing to those who have some health event or some higher need leaving Medicare Advantage.
Great, thank you.
So I have a big question, when Medicare Advantage was initiated like 10, 20 years ago with the hope to, improve care coordination, lower cost. But turns out over the last 10 years or so, the cost didn't go down and actually, in some places it went up. Right? And the Medicare Advantage is part of the equation. And it seems also to me that CMS, other agencies, they are doing a lot of work, try to, restrict the Medicare Advantage. So I want you to weigh in, for the future. Will you expect the current growth to continue, or do we flat, or we go down? What are your thoughts?
So I think that, there have been periodic recalibrations of how we pay Medicare Advantage plans. Probably the most recent big recalibration happening with the Affordable Care Act and thinking about how we set benchmark thresholds for how Medicare Advantage plans should be paid relative to traditional Medicare. While that was, expected to reduce Medicare Advantage enrollment, and because we were reducing payments to plans, it definitely did not slow down Medicare Advantage enrollment in the way that might have been expected. And if anything, plans have been enrolling even more beneficiaries after the Affordable Care Act. And I think, there's increased concern based on evidence from MedPAC and others, like as you said, that, Medicare Advantage is being paid more to cover their members than that same member would cost if that member was in traditional Medicare. And so I think I am not a political scientist, but I think there is probably renewed concern about whether we should be readjusting the Medicare payment formula to try and more closely align what traditional Medicare and Medicare Advantage, how much people cost in both programs. And that type of, if we do have some sort of realignment and payments into Medicare Advantage are cut in some way to reflect the fact that we don't want patients to cost more in Medicare Advantage, I suspect Medicare Advantage plans might not be able to do things like offer generous Medicare Advantage supplemental benefits and those types of services that are not covered in traditional Medicare.
Exactly. So because if the pie is set, if you want to provide a vision, dental, other supplement, they have to cut some other costs, right? So, and if you try to increase this part, the other part may go down. So it's kind of bubbling, you push one side, the other side will go up. So I don't know in the long run.
And I will say there is some evidence that as, Medicare Advantage penetration increased in certain areas, there might have been spillover effects in traditional Medicare, where, for example, if Medicare Advantage plans were making efforts to reduce the rate of hospitalizations, There's some evidence that hospitalizations also decreased in traditional Medicare, but it's really hard to find a rigorous study to design to be able to tease that out and be able to figure out, was it the effect of Medicare Advantage increased penetration, or was it some other factor that affected both Medicare Advantage and traditional Medicare?
Yes, great. But this is exciting research area. I think a lot of work needs to be done. A lot.
And
I don't know whether go ahead.
I was just going to say, I am excited by the fact that there's increased need for data on transparency of Medicare Advantage. And I think increased data resources to be able to study the kind of questions that are important for patient outcomes.
Yeah, exactly. So regarding, for the supplemental benefit like caregiver support, is there any national data on those plans? Because they are all individual plans, and you mentioned there are over 1,000 plans. Is there any systematic data on those supplemental benefits?
So there's data on the CMS website that has been compiled by groups like HCCompare that tracks whether Medicare Advantage plans are offering specific supplemental benefits and whether they're offered and targeted to specific groups like beneficiaries with dementia. What we don't have data on that there's been, I would say, renewed calls to get better data on is which beneficiaries in these Medicare Advantage plans are actually receiving those supplemental benefits and how much Medicare Advantage plans are spending on those supplemental benefits.
That's a huge limitation in terms of the data, right?
Yes.
Because at the end, you really want to see who received what at what time.
Yes, especially since the plan has a lot of discretion over who receives these supplemental benefits.
Wow, super interesting. All right, I need to be mindful of the time, but once again, thank you both so much for this excellent presentation and congrats on your paper. And we look forward to hearing more about your research in the future. Thank you.
Thank you for having us.
Thank you.
Thank you, bye.